So we can get started, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. And welcome to our mental health awareness session for this year, Alhamdulillah, at NAMCC. And we have our Dr. Asif Siddique, mashallah. He's been here for 20 plus years, mashallah, and 15 plus years of experience he has in our behavioral health industry. You have an expertise in child psychiatry with assessments, treatment planning, and medication management. And he practices as he described in the inpatient facilities. And mashallah, he's been a great resource to this community for many years and served many here. So we're going to hear from him today on the topic of depression and anxiety in kids, how to identify it and treat it. And subhanallah, as the newer the generations we are, we find a lot of behavioral disorders which are easy to diagnose and treat, which can go unnoticed quite a few times with some more of our vigilance and care on our side. Inshallah, we can do a better job as parents, as community members, inshallah, to help our children to have a very strong ummah, inshallah. So welcome, Dr. Siddiqui, and I'll let you take it from here, inshallah.
Well, Jazakallah khair. Thank you so much. Um, my name is Asif Siddique, and I'm a child and adult psychiatrist, uh, graduate from Columbia program, University of Missouri Columbia program in 2001. So I've been practicing in Texas since 2001. So uh, today's topic was they were asking me what topic we should be discussing, and I thought we should go to some very basic and very important behavior uh, problems in children and adults we deal with, which is anxiety and depression. Uh, so today we will be talking about what are the common anxiety disorders in children. We see how to diagnose, how to recognize them. Uh, and we also will discuss a bit about clinical depression in children and teenagers. Uh, what is the incident, how to recognize, how we treat them. Part of the reason I felt this is a good topic is because uh, most of the medical problems we deal with, cardiovascular conditions, gastrointestinal cancer, diabetes, majority of them, their onset is young adulthood, middle, later onset in life. With a mood disorder and anxiety disorder, the onset is almost always early onset in childhood. Children can suffer from anxiety, depression from a very young age. And once someone has established chronic anxiety or depression which goes untreated, it can become a lifelong problem for that person. So uh, this morning I was looking at the current incidence as prevalence of anxiety disorders, because when I graduated almost 20 years ago, we had different numbers. So at present, up to 2019, this is from CDC website this morning, we have about 7 to 10% incident of clinical anxiety disorder which have been diagnosed and treated in this country. So about 10% children will have a diagnosed anxiety disorder between age 3 and 17 at this point. The lifetime incident of anxiety disorders can be up to 30%. Majority of the prevalence is in young adulthood. On the other hand, depression seems to be a little less common, about 3% incidence in kids from age 3 to 17. but lifelong prevalence of clinical depression in teenagers, adults can be up to 18%. Uh, so if we look at different types of anxiety disorders and their prevalence, they are probably the most common mental health illness we have in this country and other parts of the world also. So I think we will spend maybe 70% time talking about anxiety disorders and maybe less with depression. Uh, the most common, what is anxiety and what is normal and what is abnormal? How do we differentiate? So as all we know, anxiety is normal and it is present in most people and not. So what makes uh, anxiety abnormal, or when is it considered clinically impairing our functioning? So uh, anxiety is a basically excessive worrying or exaggerated trigger response to a situation or stimuli. Uh, there are different types of presentations. Uh, if you look at from the point of view of younger age to the older age, the most common type of anxiety we may see in young children would be separation anxiety disorder. The separation anxiety disorder is basically, we see that in younger children. Uh, so you have a child which has a severe irrational fear of separation from their caregivers. It can be parents, it can be any caregiver. It can be a brief separation. Sometimes separation anxiety disorder involves parents leaving the room for a few minutes and the child has a severe reaction to that. And the fear here is something bad may happen to parent, something bad may happen to them. Uh, it, so the children are hypervigilant, they have exaggerated physiological response, they're nervous, anxious, not able to sleep, in a frightened state. Uh, when we look at older children, teenagers, uh, for example, uh, okay, are we still recording or?
Absolutely.
Okay,
Yes,
all right,
absolutely.
good.
Keep going on.
So uh, the other, when we look at older children, we have generalized anxiety disorder, which is probably the most common uh, anxiety disorder in teenagers and young adults. Um, Generalized anxiety disorder would be a child who have excessive worry, nervousness, and anxiety about normal stuff, health issues, fears, and worries about life, school, grades, family. Uh, so it's almost like a teenager with the antenna on their head and perceiving any stimuli, anything which can cause anxiety or worrying, they absorb it. So they're in a hyper vigilant state. They're in a fight and flight state, but not in a very intense version of it, maybe a mild to moderate. But it's persistent. Uh, Generalized anxiety disorder is most commonly associated with clinical depression. So most children who have clinical depression often has generalized anxiety symptoms, and almost all generalized anxiety disorder children have some symptoms of clinical depression. Then we have panic disorder. Panic disorder is a intense, it's kind of a wave of anxiety uh, comes and hits you without any triggers. And in panic disorder, we have severe physiological reaction, arousal involving severe physical symptoms, chest pain, dizziness, palpitation, excessive sweating, belly sinking. You have a sense and feelings of I'm about to die, I'm going insane. And the feelings are so uncomfortable that individual does not ever want to have another one of those panic attacks. Now, these symptoms may not last more than 15-20 minutes. And in between two episodes, in general, you're okay. You don't have excessive, exaggerated nervousness or anxiety or worries, unlike generalized anxiety disorder kids. But there is an underlying fear of having another panic attack, which can lead to avoidance. So agoraphobia would be avoiding an activity which may trigger a panic attack. So panic attack or panic disorder goes untreated, unrecognized, then it can lead to developing agoraphobia later in life. The other type of anxiety disorder would be, we talked about generalized anxiety disorder. So OCD or obsessive compulsive disorder. Obsessive compulsive disorder is less common than generalized anxiety disorder or panic disorder. However, it can be very debilitating. And basically, in obsessive compulsive disorder, a child or adolescent uh, persistently is bombarded with intrusive, repetitive um, ideas and thoughts which are irrational. Younger children may find these thoughts rational, but adults and older kids may find these intrusive ideas irrational, don't make sense, but I cannot help having those thoughts coming in my mind over and over. Now, these thoughts, intrusive ideas can be related to fears and anxiety about germ and dirt and grime, or fear of safety. And these are very anxiety provoking thoughts. And the only relief one can get is by involving a ritualistic activity to relieve that anxiety. So if you're worried about dirt, germ, grime, diseases, you may get involved with excessive washing rituals, or spend too much time in bathroom, taking shower, or washing your hands over and over. And every time you go through that activity, the anxiety decreases. However, after a few minutes, it builds up again. So we get involved in a ritualistic activity again. So obsessive compulsive disorder involves intrusive thoughts. It may involve compulsive behavior. It may not involve compulsive behaviors. So the other examples would be certain ritualistic activities, stereotype is having certain things in certain order, otherwise something bad may happen. Uh, and it can be uh, obsessive compulsive disorder is probably the most difficult condition I treat in some children. It's very difficult to treat, and sometimes it does not respond to medications or therapy. The other anxiety disorder we need to talk about is would be specific phobia, fear of some specific stimulus or event. It uh, can be height, it can be a disease, it can be um, a specific stimuli, not necessarily worrying about everything, but severe fear of one thing. Uh, the only last, I think there are some rare anxiety disorder which may happen in children. For example, very interesting case, which would be selective mutism. Selective mutism is a child who's um, similar to social phobia, have, well, we didn't talk about social phobia. I think we will talk about social phobias next. So a child will have severe fear of making fool of themselves, or having severe anxiety to talk in social settings. So they may be able to communicate and have a normal speech at home, but not in a social setting. So selective mutism children usually are able to talk to their family, but no one else. Sometimes they may be able to talk to their teacher, but no one else. But majority of the time, they're not able to talk outside their home. So the social phobia we didn't talk, which is very similar to selective mutism. Social phobia is that when you have, so all of us have some type of anxiety about being in social settings. Some of us are shy, some of us are not, but social phobia would be a severe, painful, extreme shyness, mostly involving social interactions. So you have a pervasive feeling of being judged or uh, have a thought of people judging or scrutinizing me, and that may cause me to make fool of myself, which prevents from people from getting involved in certain activities, uh, public speaking, speaking in front of the classroom, um, those type of things. So this fear leads to avoidance and school refusal, which is the number one cause for school refusal. Usually, is social phobia. So when you combine these different types of anxiety disorders, um, we realize that uh, they are the most common behavioral problem in children and adolescents. And sometimes these anxiety disorder can be transient. They may go away themselves, but majority of the time, if they're not treated or diagnosed or properly treated, they can be lifelong. Uh, and untreated anxiety disorder in general leads to a pervasive sense of hopelessness, and clinical depression may become a presenting problem for these kids. So, what is the comorbidity overlap clinical depression and anxiety disorder? Uh, most kids with generalized anxiety disorder, up to 70% of them also have clinical depression. People with clinical depression up to 30% incident of having a comorbid anxiety disorder. Part of the reason these are so, the comorbidity is so high is that neurotransmitters involved are the same for both in conditions. Some of the stressors and triggering factors are the same for clinical depression and anxiety also. So, as opposed to anxiety disorders, clinical depression tends to be not as common, or at least used to be. Uh, this last 2 year COVID onset and this pandemic may have increased the incident of clinical depression. However, when I was looking at National Institute of Health data, they did not noted a significant increase in clinical depression prevalence from 2013 to 2019. The incident was about 2.3 to 3%. Kids between the age of 3 to 17 having uh, onset of clinical depression in that age group. Uh, Clinical depression, what is abnormal depression versus normal sadness we may feel due to different stresses in life, involves not only a pervasive sense of sadness, it can involve, especially in children case, a variety of other physical symptoms. It can be severe mood irritability, it can be severe rejection sensitivity, uh, changes in mood, behavioral patterns, meaning lack of um, pleasure-seeking behaviors or finding pleasure in any activity. It can clinical depression usually involves sleep disturbances, initial insomnia. Terminal insomnia is more related to clinical depression. Middle insomnia, when we wake up a lot, we're able to fall asleep and uh, sleep, do not wake up early in the morning, but frequent awakening in the middle of the night is more related to anxiety disorder than clinical depression. So appetite may go up or down. Sometimes, mostly adults may not uh, eat as much, but sometimes you see teenagers having more appetite and binge eating problems. So clinical depression also involves um, a sense of helplessness, worthlessness, and hopelessness, which results in suicidal thoughts, self-injurious behaviors. Um, so, due to self-injurious behavior and suicidal thoughts and suicidal attempts, even though major depressive disorder may not be as common as anxiety disorder, it is a significant concern in terms of kids. Treatment, the assessment and treatment is more important. We look at data of completed suicides and suicidal attempts in last 10 years, and it has been gradually increasing in US. And that was the time when FDA put warnings, I think 10, 12 years ago, that's when FDA recommended the antidepressant use should be limited in teenagers, and there's a higher risk of having suicidal thoughts from use of antidepressant medications. So that type of warning dramatically decreased the use of antidepressant in adolescents and kids. And we are seeing significant increase in suicidal attempts and completed suicides in the last 10 years, which has been gradually increasing. So the data we don't have completed yet because it's too early. However, there was a significant increase in suicidal attempts and suicides in last 2 years, up to 250% more attempts. Children were admitted due to suicidal attempts in psychiatric hospital between 2020 uh, compared to 2019. So 2020, 2021's suicidal attempts and completed incidents have gone up about 2.5 times. Uh, when we look at clinical depression and the importance in young adults and teenagers, uh, it is a serious and significant concern. Second most common cause of death in young adults after unintentional injury or accidents. Um, 47,000 deaths with suicide in 2019, which is almost twice as much as homicidal deaths due to homicide. So when we look at children with clinical depression, we often, almost always, in my case, I almost always find an associated anxiety disorder attached to those kids or overlapping symptoms. One of the conditions we have not talked so far is post-traumatic stress disorder. Post-traumatic stress disorder has historically been part of anxiety disorders. However, at DSM-5, now they have a separate category for it, which is a trauma and stress-related conditions. Post-traumatic stress disorder involves exposure to a trauma or perceived trauma and having recurrent vivid thoughts, memories, and recall of that trauma uh, with or without triggers. Majority of the time, patient will experience a trigger or stimuli which may bring about the memories of their past trauma, and they may start reliving that trauma again. And if they're sleeping, they may have nightmares. If they're awake, they may feel they're going through the same situation in the form of a flashback. So that triggers chronic hypervigilance, chronic sense of flight and fight reaction, and they may, it may involve avoidance, agoraphobia, it may involve insomnia. So the um, hallmark of PTSD is history of trauma or perceived trauma and reliving the trauma constantly, even in some cases years after the incident. Um, so we talked about different types of anxiety disorder. What are the how we recognize one from another. We talked about clinical depression how it may be a little different in presentation in teenagers and children compared to an adult, which may present more melancholic, sadness, isolation, withdrawn type of behavior. Teenager may have other associated symptoms. In general, teenagers and kids tends to have more somatic problem when they are experiencing depression and anxiety. They may come in with more symptoms of um, headaches, pain, insomnia, appetite changes. They may have multiple physical symptoms which we cannot find cause for. Uh, so that is a main difference in terms of a classic melancholic type of adult clinical depression versus teenagers and young adults or anxiety. Uh, so what is the good news? The bad news is that I guess we'll talk about the bad news. The bad news is that majority of the mood disorders and anxiety disorder just do not go away, especially in the cases where there is a strong family history. And unfortunately, most mental illnesses tends to have a stronger family history of some mood disorders or similar disorders. So children with a strong family history of mood problem tend to have earlier onset and longer protracted course of illness, uh, both in clinical depression setting and in anxiety disorder settings. Uh, so the good news is that if we recognize, assess, and treat children for these conditions, um, in some cases, anxiety is curable, and most cases, a significant improvement and for general functioning can be achieved. Now, treatment can be psychological therapy, talk therapy involving, interpersonal, cognitive behavioral, or family-based therapy, or it can be combined therapy when we add medication to the mix. So, in terms of general population, especially in our Muslim community, is a sense of too many medications prescribed to too many children, over usage of medication, over diagnosis. So just looking at the numbers, um, up to 20% of the general population may have a mood disorder or anxiety disorder, lifetime prevalence. And if we were even close to treating these people with medications, use of antidepressant in general population would be like the level of multivitamin, which we don't have. So unfortunately, majority of the children and teenagers with anxiety, depression go unnoticed, undiagnosed, and untreated. More than 75% do not get treated. I think that number is significantly higher in Muslim population. Uh, in my experience, parents have severe resistance and pushback for any type of mental health diagnosis or treatment, as we know already. Uh, so there have been studies, a lot of data available now that treatments do work. In general, uh, we almost always start out with primary care physician, pediatrician, psychotherapist. Majority of the children are able to be treated by just talk therapy. In general, I always feel a combined approach works well. Uh, we feel that if you use part cognitive behavior therapy, part interpersonal, I think, and family based, that probably is the most, we get most outcome out of talk therapy. Cognitive behavior therapy, we start out with reducing the stress and recognizing feelings. For example, therapists may start out with just simple stress reducing exercises, breathing, relaxation techniques before they start talking about what is the abnormal cognitive thought patterns are, how to recognize and how they affect your depressed mood or anxiety. So working on abnormal behavioral and cognitive and then overall behavioral techniques is basically cognitive behavioral therapy. But in order so it's almost like taking a class or course where you are actively involved and the patient has to do a lot of work. They get homework and you have to uh, work at it. So interpersonal therapy or family-based therapy involves using support from family, friends, and improving social skills. So we are using auxiliary help around you. So not the focus is not as much, and you have to do all the work. Interpersonal or family-based therapy will involve we all have to work, help you. Not taking necessarily increasing the accommodations from parents, but improving the abnormal accommodations our parents are also involved in that. So uh, medication-wise, there are few medication approved for anxiety disorder. There are only two medicine approved by FDA for clinical depression in children. One is fluoxetine or Prozac, age 8 and above for clinical depression, and Lexapro, which is approved for teenagers for clinical depression. We have a few medications approved for obsessive compulsive disorder in children from very young age, including Zoloft, Luvox, clomipramine, uh, and Prozac. So there are four medications which are actually FDA approved medication, four or five, Zoloft, Prozac, and I think Luvox, they all are approved for obsessive compulsive disorder. So because there is a medication approved for one indication, doctors often may use the same medication off-label. For example, we may use Zoloft for clinical depression, even though Zoloft is actually not approved for clinical depression. It's approved for use in anxiety disorder and OCD in children. But the data is significant and the effect size in some cases is not as great as antibiotics or ADHD treatment, which can be effect size of 1 to 2. We may have zero point 0.4, zero point 0.5 effect size, but the combination medication and psychotherapy combination does seem to uh, improve uh, and in some cases cure anxiety disorder. Definitely, it can be achieved. So um, I feel if we have general recognition of what your child may be experiencing, if you have some general ideas of how these conditions present, it would be the first step to kind of recognize and seek help. I can go into a lot of detail in terms of phenomenology or neurotransmitters, but I think we may stop now and see if anyone has any questions. We have only two other participants.
Jazakallah khair. Alhamdulillah, this is very good. Alhamdulillah, and with the participants, Alhamdulillah, people will listen to it, inshallah. So as and when it will benefit a lot to the people who listen later also. A few things I did find very interesting was I know I deal with the adult aspect of it. So the onset that you said at the age of 3 years, that was a little, quite
Yeah.
surprising to me, honestly, because I'm like, as parents, we tend to understand, oh yes, we look at some of these aspects in children who are, developing and growing, and part of it is a development. It is a
Yes.
developmental process, and between 3 and 7 years is, or 3 to 5 is your neuroplasticity. That is when it's more of an important time to recognize these
Yes.
and do the action at that time. and
Yes,
do the
exactly.
appropriate modifications which will help these children inshallah later on to do much better as they grow up into teenage years and adulthood inshallah. And another very interesting part is, as you did mention, that as a community we still feel mental health is a taboo. We do not yet understand it as much, and part of it is because objectively, as diabetes, as blood pressure, you see the number, you're looking at a particular number. Here, you are looking at a behavior, you are looking at something very subjective for an individual, and you are looking at that. So, it's for every individual it is different, and it is very hard for people sometimes to understand what could be the norm for the society versus not. But a very good
Yes,
parameter is functionality.
yes,
Functionality, look at whether that individual is functioning, whether they're taking their maintaining their hygiene, doing their routine activities that they're supposed to do, at least not. We all are shy sometimes participating in social gatherings, as
yeah,
we are, very social human beings. But it may not be a thing for everyone to go into a big gathering. But yes, do they have friends? Do they have some
yes,
people that they talk to? Are they interacting with the teacher about their needs? It should not be that the child goes without discussing with anybody for days just because they're very, very scared, and that's their anxiety. That's where we need to find out and kind of dig more in those years. And the integrated therapies really help,
yes,
they really make a big difference. When, especially now, we have something called as parent child integrated therapy. Is that right? um
yes. So, you know, um, the different terminologies like
right.
the family-based therapy, it kind of almost overlapping with interpersonal therapy. So, but I feel, you know, the research is more for does cognitive behavior therapy helps or works for mood disorder. But I think we will have more studies done in terms of family-based or interpersonal or family-based therapy, which is more integrative in nature,
Right.
where the child is not the only focus and he has to or she has to do all the work. Uh, it's involving the abnormal patterns from family and social context they have. Also, so that uh, wraparound kind of approach seems to work well for. We don't have a lot of data based on most of the studies we have is like 5, 10 years, 20 years older. They do not have as much research for family-based therapy versus cognitive behavior, which has enormous data available. But I think, like you said, integrative approach is always more helpful. So one of the things, like we just talked about, is most of these children who are experiencing social phobia or extreme shyness, they have a desire uh, to actually have friends and social contacts. Uh, it can be very paralyzing and debilitating. Uh, Sometimes these children will throw these warning signals. They may act out. Uh, they may get involved in more destructive type of behaviors. So recognizing uh, it is our job as parents to recognize what your child uh, is experiencing, not necessarily accommodating, which may increase more and more avoidance behavior, I think. Accepting, acknowledging, and altering accommodations would be the better approach, which when you work with a therapist, this is what their goal is. Um, yes, so I'm sorry,
No,
I
no,
didn't mean to.
absolutely. As you
Go
said,
ahead.
acknowledgement. I mean, it's very important sometimes, because what we, and I'm guilty myself of doing that. Sometimes when the child is like, this is scaring me, and then the next line you say is like, what's scary about this? And it's like, no, it is scaring the child. Just at least acknowledge that feeling. Oh, I see you're scared. Okay, tell me more. Why is this scary to you? And that changes the whole lot for that child, because it's like you are acknowledging the feeling, and then you go from there solving the problem. It is it it is very important to do that, and then take it from there, because feelings are are natural. They come to everybody.
Yeah.
It's not wrong to have feelings, absolutely not. It's not saying that your feelings are not right. Or if somebody says I am sad or depressed about something, it's like they are feeling it that way. Acknowledge it, then go further.
Yes.
um, so somewhere
Now we have to
we have a
accept.
question here.
Go ahead.
No, we have a question, I was saying. So if child mentions that he or she is depressed or has anxiety, when should a parent worry about it or seek help? As a parent, if your child comes to you and approaches and says,
Yeah.
okay, I am depressed or I am anxious, when should you worry and seek help about it?
So uh, there are different levels of, you know, uh, how a child is experiencing, how much they're suffering from. So a majority of the time, these children, before they come and acknowledge to parent, they almost always are hinting, throwing different signs out all along, actually. Again, like you said, how much the functioning of the child is affected would determine how seriously and acutely we have to treat this person. If there's a significant decrease in their ability to function as a teenager, as a child, their academics is affecting their interpersonal social interactions are affected, then I would always start out with, like we said, acknowledge, and then I would start out with uh, a counseling or therapist appointment. That would be the first step. Uh, Majority of the time, your PCP or pediatrician is the first contact because of such a referral. Uh, I feel there are very few occasions when a child will actually come and acknowledge to parent. Uh, so if they are acknowledging seeking help, I would, this is the time. The majority of time, we don't have that luxury. Majority of time, you have to do some, uh, you know, uh, calculations and look at what are the things going on. They're hinting about different signs maybe going on all along. Majority of the time, kids are very reluctant to acknowledge and seek help. So if they're seeking help, this is the time we need to start, probably with either pediatrician or therapist immediately.
So what I understand is, by the time that the child is approaching the parent, you're saying it's almost time to go ahead and seek somebody's
Yeah.
help, at least to go ahead and see whether this is a concern, whether what level this is,
Yes.
what's going on.
Yeah.
Because sometimes children might not disclose the entire thing to the parent, but there might be something else going on inside, which is a possibility. The other thing I did want to mention is, to whoever parents will listen to this later, inshallah, there are screenings that we always do as physicians. When you take your child to the primary care pediatrician, whoever, you will always see some question papers. Some papers we give out to you. Yes, they are a lot. They are about a bunch of 10 papers we will give you, but a lot of those questions are very important, because when we as physicians look at them, we do look at those the the numbers, and when those numbers add up, it tells us something, that the child is going through something. So there are teen screens, or the health questionnaire, the patient health questionnaire, which we call PHQ, which we give up in early adulthood and teenagers, and we do those screenings, and you will find those papers when the pediatrician gives them to you. So identify them and give it to your child and let them fill it out, and if they want to just turn it over and give it to the doctor, let them do that, because we want to know these numbers. We want to get the honest answers from that child so that we can help them early.
So the one which we use a lot is called PHQ9,
Yeah.
Patient uh, Health Questionnaire 9, which is simply very few question. It takes about 2 minutes to finish.
Mhm.
It's actually designed to be filled by young adults or adults. Um, I actually use it routinely in my office. Everyone who walks in who's 14 and older, we give them PHQ-9.
Mhm.
Uh, Below that age, we use parent-based or teacher-based rating scales, would be like Vanderbilt or other rating scales. But uh, PHQ-9 officially was diagnosed for 17 and older or 18 and older, but we use it frequently in 14 and older kids, virtually not only on a diagnostic first visit, but virtually every visit, whether
Yes.
they're coming in for clinical depression or ADHD, bipolar disorder, autism. Everyone has to fill out PHQ-9 if they're 14 and older every visit in my office. So this is a PDF form available. There's no copyright. Any parent can download, print, and have the child just fill it out, screen, and if it's significant score, then we should immediately talk to the pediatrician. The good thing is that PCP and pediatricians um, over the course of last 20 years have significant more training in this area than before. When I was in medical school, we didn't have these screening questions. Uh, but now almost all pediatricians deal with these issues on a daily basis, primary care physicians too. So now we are training our primary care doctors for mental health. Probably 30% of the time they are dealing with some of these issues. So, but in my experience, when a child is asking help, it's already been a while that they're suffering from for a while. Majority of the time, they don't come out. I think what has happened in the last 2 years or so, the the pandemic has um, significantly increased the stress on teenagers and kids. Uh, in my uh, office, majority of the kids actually do not want to be home. They want to go back to school. They do not like virtual school. They want to have their school experiences, social contacts, not only the friends, but the social context of being in a school setting. And they want to have that uh, feelings and context. And being home, virtual school in last 2 years or so has caused multiples of stressors in teenagers. It may be in the form of, relatives getting sick and dying, or parents losing their jobs, or family home may not be equipped to have 5 children and parents working from home and is attending school virtually. So uh, I feel we are going to find out more because these statistics and data based studies take much longer. What is real impact of this pandemic on mental health of children? But I think there is a significant increase in suicidal attempts, suicidal completed suicide in last few years.
There's one more question. So, when someone is experiencing an anxiety attack, do you just let them be, or we should do something like talking to them?
So I think what we're talking about is a panic attack. So there is a condition called panic disorder when you have very specific uh, kind of wave of anxiety comes and hits you when you feel severely aroused in terms of physiological reaction, like you perspiring, your chest is hurting, your heart is racing, you feel you're about to die, or you're going insane. So that's very painful. Uh, so we allow person or child to relax at that time. It can be extremely painful for them. Majority of the time, adults will end up in a ER fearing that they're having a heart attack. So uh, anything we can offer to help them relax, let them have some learn about some breathing exercises, stress reducing exercises. But in general, if someone is having acute panic attack, it needs to be properly treated because it is devastating for the person. It may be not life threatening, but it's extremely anxiety provoking and very painful for that particular person. So you should seek help for those children. I think they're having panic attacks,
Yeah,
anxiety attacks in general. Go ahead.
the panic attack is different than just in anxiety. That's what I wanted
Yes.
to comment about, because when you're actually seeing panic, it is, you see the signs of it, like hyperventilation. You see them completely into a different, they're not listening. Basically they're just like it's a total different person in that mode. It is not somebody who's just talking to you fast or doing something like telling you, oh, I feel scared about it, or do something, but they are not with you. They are shaking. They are literally, they're not able to follow anything you're saying, doing anything. So in that moment, if somebody knows or acknowledges that they're going to set into a panic attack, they themselves, once they learn these techniques of deep breathing and sitting down, just doing those methods of relaxation, they can a lot of times come out of it, or whatever they want to use as a medium to do in that moment may
Yeah,
be helpful. But that's different than just somebody having an anxiety attack,
exactly.
like just feeling scared about something.
A typical panic attack may not be resolved in 15 to 20 minutes or so. So it's not like in 1 or 2 minutes and then it's gone. It can be prolonged actually. 20 minutes up to 20 minutes, you can be very miserable.
Yeah, there's one more thing. A 7-year-old child who has a phobia of height. The child is afraid of trying something new when, which is challenging at the playground, or climbing, or that is anything to do with height. If it comes to a height, the uneasiness and discomfort are very visible. Sometimes the body of the child freezes, and someone has to step up to help the child climb down. So the parent is wondering if anything can be done to normalize this issue, because otherwise the kid is very active, loves to play, finds it easy to mingle with other kids, only happens at particular times when it comes to a height.
So uh, specific phobias usually almost always respond to gradual desensitization. Simply put, you know, we may start out with showing pictures, for example, going one step or two step. But even if we work with a professional therapist, they're going to be doing the same thing, which a parent can do is uh, the fear of unknown is the main paralyzing problem here. And there's no way to uh, resolve that by gradually exposing. So when we expose ourselves to something which we are fearful of, nothing happened, and I'm not dead. So that uh, itself tends to resolve the problem. So with this particular case, we will take one step or two step extra a day. Uh, so if a child cannot go 10 step above height, we do one step and then two steps and three steps and four steps. So gradually we have to expose him to a height situation where which is very painful. It can be in the form of mom or dad and someone holding his hand or her hand and helping them go one step further. So we call it gradual desensitization. And that is a technique which is like first time a child is extremely fearful of going on a roller coaster, a very painful experience. And second time, if you make them go, maybe painful, but not as painful. And third time, they may be not painful, but not enjoyable. Fourth time, it may be a little bit enjoyable. And we have seen this over and over. By fifth, sixth, seventh time, the child is first in line because they're having fun now. Uh, so we have to do the same thing here. one, two step at a time every day. We gradually expose the child to little bit more height. So in a therapy setting, for example, this is a common example, a child or adult with a fear of snake, the therapist will start talking about it. They may show them pictures of snake. Then they may bring next visit, they may bring a plastic model of a snake, which person may hold. Next time, they may take them to a park or a place where they have aquarium or a zoo where they're kept. So uh, there's something called flooding, in which you would just flooding would be you don't know how a child does not know how to swim, and some time ignorant parents and coaches have just throw the child in the water and let him sink or swim, and he will come up with his own idea how to swim very quickly. It can be very traumatic. Or same example would be taking a patient and putting them in a room with a live snake would be considered flooding. But usually that's the last thing you want to do. The gradual desensitization, gradual exposure, that is a cure for this child. Just like we hold the when they refuse to go to school, we grab them and forcefully leave them in school for a day or two. And second day gets better, third day better, fourth, fifth day, a week later, they're getting ready and wanting to be with their friends. So that is another example of gradual desensitization.
Sure, and maybe talking to that child about it and say, hey, what happened? You enjoyed these activities, but that day I noticed you did this. So let's try and go for this kind of a go to this park and try this one today. And if the child does it with you, or with you being there alone with them, and then they say, okay, wow, you did that, that was amazing, let's try this other one, when maybe the others are not present and it's just you and the child, and then you do it, and then the child does well, and you positively reinforce that, and then again when they're with the others, maybe other children, they can do it in the playground by themselves, maybe just taking challenges one at a time slowly, because it could be hard. We don't know what the child is thinking at that point in time. Is he scared of falling? Has he fallen down sometime by themselves? So something like that. Then it can slowly, gradually, as you said, be approached and taken care of. Okay, I think we don't have any more questions after that. Jazakallah khair for this wonderful presentation. And inshallah, we will continue looking forward to having you more and
Sure,
serving the community. So, inshallah. And if there is anything else, we have this on the recorded, the uploads of the videos, and we will have your all our contacts
sure.
also there. So, inshallah, we can have more uh, questions, inshallah. All right, then.
Well, thank you so much for
You're
having
welcome.
me. And
Thank you.
if someone has more questions, just direct it to me and
Inshallah,
we
then we
can
will.
answer. For
Inshallah.
adults, we have some medication which can be used for gradual desensitization, but for children, we try not to use. For example, a beta blocking agent, propranolol type of medicine can be very helpful for an adult or older child. General 7-year-old, we don't use that type of medication. But if this were a 13, 14-year-old, then you may be able to um, resolve some of the severe physical symptoms by using a beta blocking agent, which prevents you from entering into a fight and fight state. So it reduces, slow down the heart rate, slows down the, so you don't have any physical vegetative symptoms. But for a younger child like that, we usually don't use medication. It can, they're not approved because it can cause hypertension, dizziness. But in adults or young adults, we use certain medications also, which can make this process much easier. All
One
right,
of the things
sorry.
that comes to no, that comes to our mind always is when we talk about these medications, is people always think that these medications are addicting, or it could be something that they're dependence. causing. So if they we start something, then they're going to be them lifelong.
Yeah.
I want people to understand that this is not the case. It doesn't happen like that. It is we don't know whether one is going to work or not. It takes time. It takes time to build in the system. It takes time to act, and then the same way we started, we slowly can go down on it. But it's a combination that whatever we know from our studies that works really best is that you combine the medication along with the environment, change that along with the therapy, and that really helps going forward and controlling these, as you said, these may be issues lasting lifelong, but the most important thing is to identify them and not let them harm your functioning, not let you go away from your purpose in life, and continue to be doing that and living healthy, inshallah. And a good diet and exercises and restful sleep is always the key to
Always important.
everything. It is
Yes.
always very
Routines.
important.
Children respond very well to routines.
They do.
They don't like changes. And if they're not used to, we need to make them used to get into routine, certain time for eating and playing and studying and sleeping. We can save a lot of problems later in life if we have structure at home, which we
Exactly.
have to follow as parents also. And we are guilty of that, actually. We are not structuring our lives, and it's affecting our children. I must say, if anything we can do for mental health for our children, physical health too, but mental health, get them good sleep pattern, 8, 9 hours at minimum every night. Make sure they're sleeping good. And there's a structure there, you know, create a routine, maybe taking a hot shower or bath before the bedtime, create a ritual and routine, and that goes long ways.
Yes, yes, because then later on, our goal is to make these kids as independent as we can later on. So when they go into adulthood, they are empowered by these things that we train them in their early years, and that goes further along, inshallah. And may Allah subhanahu wa ta'ala give us all that patience, the hikmah, and the strength to be the parents to these children that He has given us this amana. So, inshallah.
Thank you so much for having
Okay,
me.
you're welcome. And I'm going to end this session now, inshallah. Thank you,
Thank you
Dr.
so
Siddique.
much. You're welcome. Bye bye.